The definition and classification of hypertension in pregnancy and the pharmacological treatment. Hypertensive disorders affect 5 to 10% of pregnancies worldwide and remains the major cause of maternal and fetal mortality and morbidity. It is considered to be mild when the systolic blood pressure ranges between 140 to 159 mm of mercury and the diastolic ranges from 90 to 109 mm of mercury. It is considered to be severe when the blood pressure is greater than 160 by 110 mm of mercury, and it is considered as an emergency if the blood pressure exceeds 170 mm of mercury. So in this case, the patient has to be admitted to the hospital for treatment. Hypertension in pregnancy can be classified into 4 different groups. The first category is the pre-existing hypertension. In this, the woman is hypertensive prior to pregnancy or develops hypertension before 20 weeks of gestation, and the hypertension continues 6 weeks postpartum. So this may or may not be associated with proteinuria or protein in urine. Also, this is known as chronic hypertension because hypertension precedes pregnancy and continues 6 weeks postpartum. The second category is gestational hypertension, where hypertension develops after 20 weeks of gestation and resolves within 6 weeks postpartum. So, to be noted that there is absence of protein in urine and the blood pressure is elevated for a temporary period and resolves on its own within 6 weeks of postpartum. The next category is the pre-existing hypertension superimposed with gestational hypertension associated with proteinuria. The last category is preeclampsia. Here, gestational hypertension is associated with significant proteinuria. So, proteinuria may be a late manifestation in hypertensive pregnancies. However, the patient may present early with headache, visual blurring, abdominal pain and abnormal laboratory tests such as low platelet count or elevated or abnormal liver function test. Now do remember that if preeclampsia is associated with seizures or convulsions, it is termed as eclampsia. Both preeclampsia and eclampsia occurs in first pregnancy or in pregnancies with multiple fetuses or in pregnant women who is younger than 20 years of age or who is older than 40 years of age, or if there is pre-existing hypertension, diabetes, kidney disease, hereditary-form mole, antiphospholipid syndrome and so on. So this condition can cause placental insufficiency leading to fetal growth restriction and is a common cause of prematurity. In this way, hypertension in pregnancy can be classified as pre-existing or chronic hypertension, where hypertension develops prior to pregnancy and continues 6 weeks postpartum and may or may not be associated with proteinuria. Second is gestational hypertension, which develops during pregnancy after 20 weeks of gestation and there is absence of protein in urine and hypertension resolves within 6 weeks postpartum. The third is the pre-existing hypertension and gestational hypertension with associated proteinuria. Lastly, preeclampsia or eclampsia, which is a hypertensive crisis, and here gestational hypertension is associated with significant proteinuria associated with visual disturbances and hemostatic disorders. Next, we move on to the clinical management of hypertension in pregnancy, which can be discussed under 3 headings: management of mild hypertension, severe hypertension, and management of hypertensive crisis. Hypertension in pregnancy is considered to be mild when the systolic blood pressure ranges between 140 to 159 mm of mercury and the diastolic blood pressure ranges from 90 to 109 mm of mercury. The antihypertensive agents that are contraindicated in pregnancies are ACE inhibitors or angiotensin receptor blockers or direct renin inhibitors such as aliskiren. These are the drugs that are associated with adverse fetal and neonatal outcomes, and therefore these drugs are avoided in pregnancy. Second, beta blockers, particularly the cardioselective beta blockers such as atenolol should be avoided because they have selective action on the heart and they are known to reduce the heart rate and induce fetal bradycardia. Therefore, cardioselective beta blockers such as atenolol should be avoided. Next, diuretics should be avoided because in preeclampsia there is reduced plasma volume, and diuretics, by further reducing the plasma volume and causing diuretics, can induce placental insufficiency leading to fetal growth retardation. Therefore, these drugs should be avoided in hypertension in pregnant women. So, the drugs of choice in hypertension in pregnancy are labetalol, methyl dopa, or calcium channel blockers such as nifedipine. So once the treatment is initiated, what should be the blood pressure treatment target? So the blood pressure should be lowered to less than 140 by 90 mm of mercury in a pregnant woman receiving antihypertensive drug therapy. Next is management of severe hypertension in pregnancy. Hypertension is considered to be severe if the blood pressure is greater than 160 by 110 mm of mercury, and it is considered as an emergency if the systolic blood pressure is greater than 170 mm of mercury. The patient is admitted to the hospital for urgent control of blood pressure and blood pressure monitoring. In severe hypertension, pharmacological treatment that is initiated is IV labetalol, oral methyl dopa, or calcium channel blockers such as nifedipine. IV hydralazine is no longer used because it is associated with perinatal adverse effects. However, it can still be used if other antihypertensive agents fail to achieve adequate blood pressure control. IV urapidol may also be considered in the management of severe hypertension in pregnancy. Next, we move on to the clinical management of hypertensive crisis, which includes preeclampsia or eclampsia. Here, gestational hypertension is associated with significant proteinuria with associated visual disturbances, hemostatic disorders. So firstly, hospitalization of patient is necessary for immediate blood pressure control and monitoring. Second, blood pressure lowering therapy is essential and blood pressure monitoring is needed. So the blood pressure should be lowered to less than 160 by 105 mm of mercury to prevent the occurrence of acute hypertensive complications in the mother. The drugs that are recommended in the management of hypertensive crisis are IV labetalol or IV nicardipine. They are considered to be safe and effective in the management of hypertensive crisis. If preeclampsia is associated with pulmonary edema, then IV nitroglycerine is given as an IV infusion. Magnesium sulfate is administered to prevent eclampsia or to treat seizures. Lastly, delivery of the baby should be considered once the maternal condition is stabilized. So if the woman is asymptomatic, then delivery is indicated at 37 weeks. But if there is preeclampsia or eclampsia with associated proteinuria, hemostatic disorders, then urgent delivery is indicated. So in hypertensive crisis, hospitalization is necessary. Blood pressure lowering treatments such as IV labetalol or IV nicardipine are recommended. Thirdly, magnesium sulfate is given to prevent preeclampsia or to treat seizures. And lastly, delivery is indicated urgently. In this lecture, we have learned how to define and classify hypertension in pregnancy and the clinical management of this condition. Thanks for watching. Please like and subscribe to this channel.